Morning.
Good morning. This is Kelly Sheets with DMS. I will be your host for today's meeting. I have 8:32. It looks like you do have a quorum. However, I don't see Dale yet.
Can you guys hear me?
Yes, I can hear you. Renee, can you hear me?
Yep, I guess I had it on my speaker off. Okay, now I can hear you. I'm so sorry.
Oh, that's okay. I was just saying, it's Kelly Sheets with DMS, and I'll be your host for today's meeting. I believe you do have a quorum. However, I don't see Dale yet.
Yeah, Dale sent a message with the agenda, and so I'm going to be the one hosting or as the leader of this meeting today because he is in another meeting at a conference out of town.
Okay, perfect. Well, it does look like you have a quorum, so I'm going to go ahead and turn it over to you.
All right. Well, thank you. Okay, so we had some old business just following up from the Department of Medicaid. I don't know if anybody's on to speak of these issues. We can start with number one, follow up from Department of Medicaid with the Medicaid's position on increasing the OTPT ST fee schedule for 2023.
This is Justin Derringer. I am the acting director for the Division of Healthcare Policy. So we are doing 2 or 3 different studies currently at the time. We have the internal study we're doing right now with all the different fee schedules for OTPT and speech, as well as waiver. We also are currently undergoing a rate study for the 1915C home and community-based service waivers. We're kind of waiting on that rate study to be complete. When that rate study is complete, we're going to review that with the internal studies that we've completed and see exactly where we are with rates and fees. Once those studies are complete, we can do a comparison and then fiscal analysis to see exactly where we are and fiscally what we can do and where we're at with those rates. So that's kind of where we're at right now. We're kind of just waiting on that 1915C waiver study to complete before we can compare and analyze all those rates.
What is the completion date of that, Justin?
I don't have a specific date. I think it's, I mean, I think we were kind of expecting that to be done already. So it's a little bit, yeah, go ahead, Pam.
Sorry, sorry, Justin, I didn't want to interrupt you, but it actually, so it has been completed. It is, though, in the stages of the validating, the results, the quality, make sure, just looking through everything, and it's with executive staff for review. So, but the actual components of the study have been completed.
So very soon then.
This is Pam Marshall. Can you explain to us what goes into that study?
So I'll let Pam talk more about the 1915C study, and real quick, I'll go over some of our internal studies. So on the internal study, we look at the fee schedule, the current fee schedule. We look at the 2 different provider types. We look at provider type 45 and 76. We look at OTPT and speech. We look at every single code that's listed on our fee schedules. And then we look at any rate that Medicare has. And then we look at multiple different states' rates. We compare the same codes with multiple states to the codes that we have. And we kind of show those on a side-by-side comparison. And then we also look at the cost, things like cost of living and things like that, and take those analysis into effect as well. So those are the internal studies, and I'll let Pam talk a little bit more about the C study.
So the 1915C study looked at actually all of the waiver services. Therapies were not initially included because I think, as you know, based on what Mary Haas had testified in the last meeting, that the therapies are moving out of the waiver into the state plan and will just be in the waiver as extended state plans. But what went into the studies for the waivers is kind of similar to what Justin said, looking at states that surround us, states that are similar to us, also looking at what the actual cost is reported by providers who provide those services to 1915C waiver members. So it was a study of every service within the 1915C waivers.
Thank you.
Yep. All right, thank you for that. All right, so the next one is following up on the Kentucky Medicaid requiring physician signatures on the plan of care before approving PAs. Anybody on for Medicaid?
Yeah, I don't have a lot of updates on that one currently at this time, so I'll have to get back with you on that one specifically, unless anybody else has an update.
This is Pam Marshall again. I'll just add, as over the years, we've discussed this with MCOs because it sometimes is a thing that they'll try to do just as an administrative piece that's very burdensome and very tricky, the timelines on that and trying to get physicians to sign a plan of care. The language in the reg is in collaboration with, that would be the quote right out of the way. Reg is in collaboration with, and it's been interpreted because we've discussed this with the Medicaid PA department, that they're interpreting those words to mean that the physician has to sign it, but nowhere in the reg does it say it has to be a signed plan of care. It just says the words in collaboration with. So we'd really like an answer to that, because we've been able to help the MCOs understand that, physicians are very busy treating sick kids, and they refer to us as the expert to be, providing therapy, and we send them our updated plans and all of that. But it's just because we don't have some kind of national electronic system where they can just sign it and get it back to us. It just becomes, trying to chase it down, and it is not a reasonable thing, trying to get those signed and back and without having to put the child on hold, because the child's making progress, and it could take 2 to 4 weeks in some systems to try to get that from a physician. So now you've got to put the child on hold, and you've got to put somebody else in that spot, and maybe that family can only come at that time. It just becomes a huge burden that's unnecessary.
Yeah, I know. I wanted to say really quickly, we've got multiple issues that we have taken up, not from other TACs, but also just from different provider groups and provider requests concerning prior authorizations. So we're doing multiple reviews with our regulations and with prior authorizations to see if there are different ways we can ease those burdens and ease back into some of the prior authorizations, specifically the ones that were cut off during the public health emergency. So even though this is one of the issues that I'm not current on, I'm sure it's one of the ones that's, now that you said that, one of the ones that's being worked on and being looked at. I can't remember, did you all submit, I know there was, did you all submit a recommendation on how the cabinet would verify physician collaboration on those, or?
We did not.
Okay.
I don't think, I don't recall that, but if we need to, we can definitely do that, if you would like for us to do that.
Well, it's just a thought. I think for some reason I was thinking that came from somewhere, another group, maybe another provider type, and with the same issue. So That's always welcome. I'll definitely
Mhm.
look into the other provider type to see what their recommendation was on that, because I think it's similar language in their reg. But absolutely, I'll let me look into that and make sure I get an email out to the group.
Yes, and you may want to, in the meantime, notify the Medicaid PA department, because they're the ones kind of being sticklers on that particular piece. But it definitely is not clear in the reg to require that.
This is Angie with Medicaid. Just to get clarification, you're talking about fee for service or traditional Medicaid as well as the MCOs? Is everybody doing that? Requiring that?
Correct. The MCOs are not, because we've communicated with, I say we, most of us on TAC who have therapy companies that communicate with them. Like UHC tried to put this in recently, and make this a requirement. And it was one of the things that when they came into the state, I talked to them about when they came into this state that, look, you can't, because they do this in other states just to cause an administrative burden and just to keep therapy, it keeps it delayed and stops it, and you have less therapy happening, right? Because it's interrupted constantly.
Yeah.
And what's different about our services than physician services is the children coming to us are typically coming weekly.
Right.
And it's a huge disruption to that family.
Right. And
have
I
to,
just wanted to
you
get, I just wanted to get clarification there if it was only traditional Medicaid or the MCOs as well. So
Well,
you're saying that it's traditional Medicaid that's requiring this and the MCOs are not.
Correct, because we
Okay.
did get UHC to change their view on this once we explained to them why this was burdensome. But it doesn't mean that at any time, because this happens all the time, when things are unclear,
Mhm.
an MCO will automatically try to start something else. Just, UHC recently did with one CPT code, just didn't announce it to any of the providers and just said, well, we're not paying for this code. It's not medically necessary. And I said, wait a minute, it's on the fee schedule. You can't do that. So, that stuff happens to us all the time. If it's not corrected in fee-for-service Medicaid, for us to be able to say, look, this is not a requirement. It needs to be corrected in fee-for-service Medicaid because everybody else follows suit.
Okay. All right. And just as an FYI, if they change something, they have to give the provider 30 days notice. So
Yes, I realized that. So yes,
Okay,
I
good.
made that announcement to them.
Okay. All right. Thank you. So sounds like Justin's on it.
All right, thank you for that. Okay, so the next one is on number 3 is the credentialing concerns. And we had talked about just streamlining the credentialing process with the MCOs, some of those issues there. So is there anyone that would like to speak on that?
Good morning. This is Stuart Owen with WellCare. I don't know if you're aware, but there's a credentialing alliance that I believe four of the MCOs have contracted with, but we have not gone live yet. It's KHA partnering with Veresis, I think it is. So, that would definitely help, but it hasn't launched yet.
Veresis, is that with an F or?
Sorry, VERISYS.
Okay, thank you for spelling that.
Sure. And I understand four of the MCOs have reached, basically an agreement, but hasn't actually launched yet. So they will be doing the credentialing for four of us.
Okay,
And I believe it's the four with the most volume of members.
okay. All right, that might be helpful. So that is some update there. Does anybody have any other update on that? Thank you, Stuart. Okay. Is anybody that's on the TAC team have any other comments with the credentialing concerns that they want to add?
This is Pam again. No, just that it is a, burden that we need to continue to look at. And then the other issue is because credentialing and loading and all of that is so challenging that typically there's not a recourse when an insurance company suddenly kicks your providers out of network, and then it takes you 6 months to straighten it out. And it's nothing we, the provider, did. It's just happens in the system. So while looking at this, I think it's very important to have some kind of recourse for that, for like a timeline that they have to get it corrected, because it just seems like it drags on and on and on. And Renee, I don't know if you can speak to that.
Yeah,
as well.
I actually don't know if that's happened to us, but is that with MCOs or is that with?
Yes. Yeah. MCOs.
Okay. Did they just kick your company out of network?
Yes, it's happened before where like randomly they do an update to their system and somehow providers get kicked out of network. And sometimes it's only like a small group of them, or
Okay, so it's not
it'll
your
be
whole agency.
no,
Okay.
sometimes it'll be like a small,
Yeah,
but the
we have that.
issue is there should be a timeline to get that corrected, because it just seems to drag on and on and on and on and takes a really long time to correct.
Okay, so that would be a question for Kentucky Medicaid. Is that a legislation issue that would need to go in, or is that something that would be in regs for Medicaid to put in for the MCOs? I saw Judy was on. I don't know if
I'm not sure. This is Dr. Terrio. I'm not sure.
okay.
There
All right.
are contractual requirements of the MCOs regarding credentialing. I'm seeing if I can find the specific information on that right now, but there are credentialing requirements.
Yeah, we do have the 90 days, but we don't, there's nothing, that's initial credentialing. There's nothing that's holding them accountable to this problem when you're just humming along. You have everybody credentialed, and a group of your providers gets, now their claims are paying is out of network, and there's no timeline to get that fixed. There's nothing really to hold them accountable other than we're working on it, and that happens. And typically it takes, in my experience, 6-7 months before things are straightened out. And chasing claims to get reprocessed and all of that.
If you encountered those types of issues, you may submit a complaint to our health plan oversight division, and there is a link on our website that has that complaint form that could potentially help you get this resolved quicker than 6 or 7 months. I don't know if you've ever tried that route or not, but
oh yes, you are very familiar with our complaints. Sometimes it doesn't work. I'd have to go back and look at examples, but it still drags on because it has to be fixed in the system, of that MCO.
So, Angie, would that be something that you guys could look at putting in the rules and regulations there, as far as like, if this happens, somebody's been credentialed, maybe it's a 3-month, like no more than 90 days. Is there any kind of writing that could be added to that?
it's something that we can look into.
Okay, thank you. Okay, number 4, is there any resolution on Aetna not paying for the CPT 96112 developmental testing?
So I was mistaken. It actually wasn't Aetna, it was Anthem. So that's my bad on that. I've been speaking with a lady from Anthem, Aetna, about that, some other issues. So she's aware that it was not them for the 96112. Anthem, I do need to find out why it is that they're denying that, saying it's a mental health code. That's what they were saying. So I'm not certain. So that's not resolved, obviously, because I had the wrong insurance company.
And this, can you hear me? This is Kathleen with Anthem Kentucky Medicaid. And just yesterday, I did see some communication going on about that code 96112. And we did clearly state to our provider rep and claims that it is a therapy billable code. I know that there is information being passed on. I didn't see if that was specifically what therapy provider, but I know there is discussion
Okay,
on that. Thank you.
thank you.
Mhm.
Okay. All right. So that was all that we had on the old business. So moving on to the new business. We had on here, when will the 2023 Kentucky Medicaid OTPT speech fee schedule be published?
I thought it was already up.
That's what I was gonna
Last
say.
week. It's up.
Yeah, it is.
Oh,
It
was
is
it
currently
last
up.
week?
Yes.
Okay. I did not see that. Okay. I was secretly hoping it was going to have a magic increase in there, and that's why we weren't putting it up there.
Okay.
All right. Tamara, did you want to say something? Okay. All right. Well, is there any other new business? I did have one come in on my phone here.
Yes, Renee, it's me,
Okay.
Pam Marshall.
Okay. All right. Go
I
for it.
wanted to know if anyone else was experiencing, back in 2016, we had an issue when WellCare hired Evacor and began restricting prior authorizations, not based on the required medical necessity criteria from Interqual or Milliman. And it's happening right now with speech, and Humana MCO has hired Evacor. So it's definitely an Evacor issue, but they're not following medical necessity criteria. And the reason that's provided in the denial is just very generic, that it hasn't, met medical necessity criteria. But we know the criteria very well, and we're looking at the documentation, and the documentation's meeting medical necessity criteria. So I'm wondering if anyone from Humana MCO can find out if they are indeed following Interqual criteria or not, because it's not clear to the provider that they are when we're, requesting the reasons why the prior auth is denied.
And Pam, I did ask my revenue cycle director, and she said that we have had some as well, and they've had to contact them. She said that they've been opening them back up for us, but it is, again, administration burden. So
yes, that's the same that's happening to
yep.
us, and it's literally been every single one. So you always know there's a big red flag when that starts happening.
Yeah, so it has been happening to us too. So is there
And
anyone-
limiting, the other thing they'll do is they'll give a prior auth for 6 or 2 visits or 6 visits over a 90-day period or something like that, a 12-week period.
Is anyone on here from Humana that can speak to that?
Hi, this is Samantha Harrison with Humana Healthy Horizons in Kentucky. I believe that Pam Trigilio has addressed that, but Pam, can you speak to the communication you've had with providers related to Evacor? And we also have Kathy Kaufman on, who's our Associate Director overseeing utilization management, who also works with Evacor as a subcontractor. So both can possibly address the questions that you're having. Pam?
Yeah, so good morning, Pam Marshall. Yeah, I just sent you this morning Evacor's answer on all of those concerns. And I believe that is related to your request for a call between Evacor and our UM teams. Is that correct?
Yeah, I did request that.
Okay. Yeah, they gave some pretty extensive responses to what you sent. So you may want to review that and then let me know if you'd still like to have that meeting, and I'd be happy to set that up.
Okay, I will review that. And in the meantime, if anyone else, any other therapy provider is having that issue, maybe we can work on it together.
Kathy, would you like to address the clinical criteria by Evacor? quickly. I believe you're on mute. I can see her talking and I don't hear her.
Double muted. Evercore does have their own clinical criteria that sent to the department and approved. But if there is questions about the specific denial reasons, we can always research that and send it back to you on specific cases.
All right.
So
And like
you're
I said, we
saying,
are more than happy to go ahead and set up that meeting, Ms. Marshall, get it on the books so that we can have a discussion. So happy to do that.
yes, I would like to do that. So you're saying that Evicore's using their own criteria that they submitted to Medicaid to get approved, because the reg says it has to be interqual or Milliman. I mean, it says specifically what so can anyone from Medicaid speak to that? Because I don't think you can go outside of that reg.
Actually, we have the ability based on contract to get additional criteria approved by the department. And we followed that process with the implementation of Evicore. I'm not Medicaid though, so I don't know if there's anyone on the department's staff that can speak to that as well.
And
This is Angie with Medicaid. Yes, Milliman and/or Interqual is the primary for medical. But yes, to what Ms. Harrison Humana says, if Medicaid has approved their criteria, it is reviewed. And they are able to obtain approval for Evicore's criteria.
And so I just wanted to say, I think that right there just sort of talks about the issues in itself where there's so many, and I know that we don't have time to discuss this today, but this is something that I know several of us providers are concerned about, is that there are so many different regulations for different MCOs versus the Medicaid, and it's not as streamlined. And so when we go back to looking at our fee schedule and when you compare Kentucky to other states, there is so much more, and I'm in 3 states myself, so I can tell you the administration burden in Kentucky is so much more than it is in Tennessee and Indiana. So if you're comparing states to states, you have to look at administration burden too when you're looking at our rates in general, because you are we have to have so much more manpower to man Kentucky's MCOs and Medicaid than we do in other states. So I think that that needs to be taken into consideration with these work studies for financials when you're looking at that, and it cannot be a comparison exactly for a state to state rate. So I do want to add that. I would also love for the Kentucky Department of Medicaid to look at how they can streamline these so that there are not so many administration burdens for our providers and the MCOs, and that they're, the MCOs follow the Medicaid guidelines, and they're not able to, it's so hard if you have a company and you have multiple locations and multiple MCOs that you contract with, and because at the end of the day, you're just trying to help the kids. It is so hard to understand that, oh, Humana changed it to this. Now Anthem's doing this, Medicaid's doing this, Passport's doing, Molina's doing this. So there's just so many things. I think as a group at the TAC, we would all come together to say, is there anything Medicaid can do to decrease the burden and help streamline these across the MCOs?
I would second that, Renee. It's Pam Marshall speaking again. It just like this example of what we're experiencing now, the rules of prior authorization now for Humana MCO with Evicore's, with these mystery standards that's been approved. They're also asking for developmental assessment or scores or whatever, and Medicaid doesn't require, I mean, there's some children that you can't complete standardized scores on. So we've been round and round over the years with that as well. And so there's not much that we can do. We don't have the control to change the criteria that they're using, but it's pretty much cutting off, it's just a big red flag when you're a provider trying to help children. And now most of your PAs are being denied and you have no real reason why and no understanding why. I think it's just a problem that the providers aren't in the rules of the game is changing and we're not in it.
Thank you, Pam. Anybody else have any other new business that we have not addressed today?
I have a question, Renee. This would be I guess it's really for everybody. It's about interpreters. So our understanding is that MCOs have interpreters that we have access to potentially, but the problem is that the member has to initiate that process. So, there's just so many things wrong with that whole setup, with getting someone who doesn't speak your language to initiate getting an interpreter on the phone. And, it's just a nightmare. So I guess my question is, why is it set up that way to where a member has to initiate that? I mean, we're initiating authorizations and checking benefits and we're doing all that for the member. So why can we not also do this? I guess I just am unsure. So it's just really difficult for us to be able to access those interpreters.
Is there anyone on that could potentially help address that at the MCO level in Medicaid?
This is Stuart Owen with WellCare. I just know that we have to provide interpreters. I'm not aware of a requirement that it absolutely has to be the member that initiates and the provider or provider staff can't assist the member. I'm not aware of that. I can research it, but I'm not aware of that.
And this is Justin Derringer with Medicaid. I'll definitely take that back as well and get you all email and see what we can do.
This is Samantha Harrison with Humana. We can share with the TAC the information that we shared with other TACs on interpreter services that we offer, if you would like.
Yes, that would be great. Do I need to put my email in the chat or are you going to send that out to the group?
I would send it out to Kelly Sheets to distribute.
Okay, thank you.
Okay.
Thank you, Samantha.
You're welcome.
Question, Justin, I guess this would be maybe for you. If we are lucky enough to get an increase on the fee schedule, would that be something that would be backdated to January 1 of 2023?
No. So if we decide that, during that analysis that's something that we can do moving forward, then it would start from whatever date it was, that it was changed. It wouldn't retro back to January 1st. So the fee schedule that came out for 2023 is what's on January 1st. And any increase would be from that point moving forward.
Okay, thank you.
You're welcome.
Okay, is there other, sorry, losing my voice. Is there any other new business?
Hi, can you all hear me?
Yes, ma'am.
Hi, sorry, I was speaking, but no one could hear me a second ago. This is Holly Owens, and I'm with Anthem. Just to touch on the interpreter services for Anthem, we do have a form that providers can fill out, and they send it to and they can fax it to our case management department, and they set up those interpreter services. So I can get more information on that, and then we can pass it along to you guys too with the fax information and the form that you all can have.
Okay, thank you.
Thank you.
And this is Crystal with Passport. We actually just created a whole kind of sheet that explains how you can request different types of interpreters, whether that be in the office for face-to-face, ahead of time for an appointment, things like that. Providers can request it by calling in. So I will share that with Kelly Sheets to be distributed as well.
Okay. All right, once Kelly gets that to us, we will get that out to the providers. We'll get it out to our different associations there. Okay. Does anybody else have any other new business? Thank you, Holly. Okay, with that being said, our next Therapy TAC meeting is going to be Tuesday, May the 9th, 8:30. And would anybody want to I guess, I don't know, Holly, do I need to have, or not, do I need to have somebody approve the ending? This is my first time to do this meeting, so I apologize. Or do we just adjourn?
Hi, Renee, it's Kelly. You did not approve the minutes, so if you want to go back, and I would just ask, in order to comply with open meeting laws for all of the TAC members, if you're voting, to please have your camera on during the vote on those minutes. And then no, you do not have to have a motion to adjourn.
Okay. So
Renee, I make a motion to approve those minutes from last.
Thank you, Emily. All right. Yeah, so this is my first time to do that. So I did not do that. So I apologize. So thank you. Okay. All right. So the minutes have been approved. And Kelly, can you give your email there for Crystal?
Yes, I can.
Okay. All right. And then everybody else, I hope you guys have a great day. Hopefully it will warm up soon. And thank you guys for being a part of this meeting. And I will go ahead and adjourn.
Thank you. Have a good day too.
All right. Bye, guys.
Thank you. Bye-bye.
Hi.
Thank you.